you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinosa, the Program Coordinator at CSCLA, and I'm honored to welcome you to this week's webinar titled Financial Toxicity, Moving Toward Patient-Centered Solutions. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we'll get to as many as possible. And to introduce today's speaker, Dr. Margaret Liang is an Associate Professor and Fellowship Director in the Division of Gynecologic Oncology within the Department of Obstetrics and Gynecology at Cedars-Sinai Medical Center. She completed medical school and obstetrics and gynecology residency at The Ohio State University. She subsequently graduated from the Cedars-Sinai and UCLA combined Gynecologic Oncology Fellowship in 2017. During that time, she attained a Master of Science in Health Policy and Management from UCLA. Her research interest is in developing multi-level interventions to address the financial hardship that cancer patients and their caregivers face during cancer treatment. She currently serves as a co-investigator for the Emotional Wellbeing and Economic Burden Research Network, which aims to stimulate innovative and collaborative research to better understand and address the impact of economic burden of disease on patients' emotional well-being. It gives me great pleasure to welcome today's speaker, Dr. Margaret Liang.
Thank you, Abby, for the nice introduction. Happy to be here today. All right. All right, so yeah, very pleased to be with you all here today on this Friday before the holidays come up. So thank you for taking the time, and I definitely look forward to hearing questions that people have at the end. All right, so I have some disclosures. They're all unrelated to this talk, but research funding and consulting are listed here. All right, so I wanted to talk about the term financial toxicity. It's a term often used in the research world, but I do think it's very pertinent to patients and their families and loved ones. So when we think about cancer treatments, medical providers often think of the side effects of treatment as the word toxicity. So traditionally, you might think of chemotherapy and having symptoms like hair loss or nausea and vomiting or fatigue. And so a little over a decade ago, an oncologist actually thought, another one of the actual side effects that's probably under-recognized is the distress or hardship that can arise actually from the financial burden of cancer treatment. So we should really start thinking about financial toxicity or the financial burden that patients and their loved ones are experiencing as another side effect of treatment that we need to identify, help prevent, and help patients deal with. So on the right here, you can see there was a New York Times article in 2019 by Susan Gubar, but I thought the headline underneath the title was just very interesting. So while medicine transforms cancer into a chronic disease with which patients can live for an extended period of time, financial toxicity also threatens to turn chronic. Okay, so when we think of the costs of care, the two main buckets I like to think about are we might have monetary or out-of-pocket costs of care, and we might have time costs, which are more indirect. So on the left, if you see here, direct out-of-pocket costs, I just provide some examples. So there could be medical out-of-pocket costs, so payment for provider visits, lab work, imaging studies, treatments themselves, medications, and supplies. And then there's also a whole category of non-medical out-of-pocket costs. So this might be transportation to and from visits, parking, which can sometimes be quite expensive, lodging, if someone lives far away from where they're receiving medical care, or have very intensive treatments like daily radiation as an example. On the right, you can see we have the time costs. So maybe these aren't measured with money specifically, but these actually still also have a very important impact on patients' day-to-day lives. So you can think, okay, what are the when people are you know, doing things to do their cancer care. Oops, sorry. You know, what else would they be doing otherwise? So this might be working for an income, going to school, taking care of children, taking care of older individuals, or spending time with their loved ones. Okay, so interestingly, I described why we use this term financial toxicity, but now there's a new term called time toxicity. So really acknowledging that time is another cost that patients and their loved ones are facing. So this includes time coordinating treatment. So not only the actual time getting the healthcare, but the travel time, the waiting time, maybe the unexpected or unanticipated time, needing to manage symptoms or side effects, which may be, again, expected or unexpected, and then potentially hospitalizations. And so in order to simplify things and really think about how patients are actually experiencing this, there's this push to think about a measure where you're kind of saying how many days is the patient having physical healthcare system contact. So even if patients being asked to come in just for lab work, that brief visit can really become an all-day affair if we think about all the different things that go into just getting that, again, brief lab visit as the example. Okay, so this is from the National Cancer Institute. So it's a nice diagram that does show that there is a definite link between health and financial outcomes. So if you start over here on the left, every individual has their pre-illness health, whatever assets, debt, and income they have, and then they may become sick. So in the example we're talking about today with cancer, but maybe other illnesses too. Patients may or may not have medical insurance, and so all this kind of guides into their decisions about their treatment choice. And so once patients proceed with treatment, they experience medical costs, which we talked about, the monetary and time costs, and then the different buckets of medical or non-medical costs down here. And this over time really can lead to financial strain or distress. And so I'll show you some data about how this can impact patients' actual health or cancer outcomes. And then also we can imagine that person who's having a lot of financial strain in the most severe cases could even lead to bankruptcy. So ultimately, this can really be a domino effect. So if a patient is having a lot of financial burden and this is causing strain, you can imagine they may fail to adhere to their treatment because they're having difficulty affording the care. They may need to borrow money, use their credit, or use their savings to pay for care, sell possessions or property, work more hours if they're even able to, or caregivers may take on some of this burden. They may reduce spending on necessities, and then overall, eventually may fail to pay their medical bills or even file for bankruptcy. So we really think about that there's three sort of domains of financial toxicity, and a lot of this is in the research world where we're trying to better understand how to categorize the different impacts that patients are having. So first in the, and these all overlap, you can see in the circle. So in the green circle, you can see there's the psychological response. So this is patient having distress or worry over being able to afford care. In the blue circle, we have material conditions. So these are sort of more objective things. So what are the out-of-pocket expenses? Is there lost income because the patient can't work or the caregiver is taking off time in order to help the patient go through their treatment? And then ultimately medical debt and bankruptcy. And then the orange circle is describing coping behavior. So the sort of downstream, like when all of these other things are going on, then patients may potentially delay or miss care or have lower adherence to treatment because of all these other factors that they're trying to deal with at the same time, in addition to the stress of a cancer diagnosis and undergoing treatment. So when I did a study actually with about 25 ovarian cancer patients, we did interviews with them to kind of learn more about their experience dealing with the cost of care. And so I just picked these three because they kind of exemplify or good examples of these three domains that I described. I'm not going to read the whole quote, but I'll just read sort of the highlights. So one of the patients said, when you sit in fear of answering the telephone and summons is being sent to your door, saying that you owe money, they're going to sue you. It's very hard because you've always paid your bills on time and had a lot of pride, and now it's feeling ashamed. Another patient, ovarian cancer, said, we depleted everything. We're at that. It's very scary, but we've sold everything we've had, and it's very sad. Interestingly, in this group of patients who had already established care, most of them said, you know what, it would have been devastating, but I was really, the most important thing was getting the care and just worrying about the cost later. So you can see it's a lot of things that people are trying to balance that are competing priorities. Okay, so why is it that financial toxicity is becoming more and more of a problem? So I'll show you just a few things just so we kind of understand the big picture. So there's rising costs of care. More of the costs are being put on the patient. Insurance, as many of you may know, either from personal experience or experience of others around you, insurance is complicated and there's a large lack of transparency. And then it's very complex to have coordinated care. There can be impact on work and income, and not just the patient themselves, but also those surrounding them, like their caregivers. So the main takeaway from this graph is basically the United States is the green line and the blue line is the average for comparable high-income countries. And basically this is the percent of health expenditures as a percentage of the country's gross domestic product. So the big take home is you can see it's on the rise, and it's rising more quickly here in the United States than in other comparable countries. And if we think about it, a lot of it's not the only problem, but one of the problems is that we are having really amazing new approvals, which is great for cancer drugs, but the cost of them really is rising rapidly. So you can see here this rise over time. So from 1965 to 2020 on the right, you can see this is big. And actually the big thing to know is that each of these lines actually represents like a 10-fold increase. So I just put here on the right. So in 2000, newly approved cancer drugs cost about $1,000 per month total. 2010, it was $10,000 per month. And now in 2020, it's well over $10,000 per month for these. These are like new drugs that come to the market. And then when we think about how this is impacting patients, really, again, patients are actually having to bear a lot of this burden more. So in this graph, if we look at the lowest line, inflation has gone up about 20% from 2010 to 2020. Workers' earnings went up a little bit more than that in that time, about 27%. But you can see premiums, which is how much we pay every month to have insurance, went up 55%. And then deductibles is where that's how much you have to pay out of pocket before your insurance kicks in. That rose 111%. So these top two lines, which clearly are more steep than the other ones, have risen so much more quickly than inflation or workers' earnings overall. And then again, I think, I think this probably speaks to a lot of people. So there was a survey done by the Kaiser Family Foundation, and it showed among surveyed individuals, 6 out of 10 people reported they had a problem with their health insurance in the past year, so 60%. And just some examples I'll read here. Insurance paid less than I expected. Insurance didn't cover the prescribed drug. They denied or delayed approval for needed care. The doctor or hospital I needed to go to was not covered. I reached a limit on the number of visits and services. So you can see, again, this can be really complicated to navigate. And then I talked a little bit about the lack of transparency. So there is acknowledgement that there are a lot of surprise bills. Across the country, it's thought that about 1 out of 5 bills that patients receive might have a surprise charge that a patient didn't know about. And basically, this is the concept of in-network versus out-of-network. So insurance companies have contracts with certain either healthcare providers or hospitals that they want their patients to go to. That's called in-network and has a certain cost. And if patients go to out-of-network, which would be one that's not contracted, basically they're going to charge more. And so we actually found, again, 1 out of 5. So they took the 7 most common surgical procedures, patients that went to a facility and the surgeon was in-network, so covered by their insurance. But then 1 out of 5 of these actually had a surprise bill for an out-of-network provider who the patient could have never known that they were out-of-network, because it's people like behind the scenes. So the anesthesiologist who you don't meet till the day of, the pathologist who's reviewing the specimens that were removed at surgery, surgical assistants. So this is pretty challenging of an issue. So in 2020 and went into effect in 2022, there was the No Surprises Act, which actually tries to ban surprise bills really only for emergency services. But you can imagine when someone comes in for emergency service, particularly if they come through an ambulance, they can't really control what hospital they're being taken to. So it basically bans out-of-network charges and says, even if the patient in an emergency is at an out-of-network place, you must charge them the in-network fee. And then also that they have to have more transparency about how to do disputes if the bill is more than expected. Okay, so how common is financial toxicity? So again, this is from research that's done. I did a study. I previously worked in Alabama and then also with some collaborators in Massachusetts. So we actually surveyed, I'm a gynecologic oncologist. So we surveyed over 300 gynecologic oncologists, and we found that almost 1 in 2, so 50% almost, of patients screened positive for financial toxicity when we used this validated measure called the Comprehensive Score for Financial Toxicity, which is an 11 question survey. So if we think about who is most at risk for financial toxicity, there are some consistent findings that younger people or younger individuals are more at risk. This might be because they've had less time to create savings over time. Also, if we think about over the age of 65, patients can apply for Medicare in our country. So there may be less insurance coverage for people that aren't eligible for Medicare after age 65. Not surprisingly, lower income was a risk factor for having a more chance of having financial toxicity. And then the other thing is that having insurance really was not fully protective. So we know, sure, there are people that are uninsured, and that's its own issue and barrier that can be present. But actually, there's a lot of underinsurance. So someone has insurance, but it really doesn't cover enough for the patient to be able to afford their care. Okay, so this was a study looking at colon cancer patients enrolled across the community cancer centers across the United States. The main takeaway here, we're going to focus on the green bars. So the green bars are the percentage of people, so they were surveyed over a 12-month period, these newly diagnosed colon cancer patients, who reported any of the following. So selling their home, refinancing their home, having more than 20% income decline, loans or debt, and so any of those is the green bar. So you can see at 3 months, about 1 in 4, 25% of people reported any of those. By 6 months, 50% had reported any of those occurrences. By 9 months, 63%, and then by 12 months, 71%. So as time goes on, probably because of accumulating costs, patients are experiencing these measures of financial hardship. Okay, so another study that my group has done is that recently we were trying to, again, learn more about patients' experiences. And so we went to GoFundMe, which is a publicly available site for crowdfunding, if you may be aware of it. So it's there are these online campaigns that individuals can put on websites. There's other websites as well, so not endorsing this one, but it's a common one. And so people will post campaigns to help raise money for various things, including potentially medical costs. So we basically, again, because I'm a gynecologist, looked at about 300 GoFundMe pages for individuals and tried to see like what types of things are they looking for and how much are they campaigning for. So about half of patients, or the halfway mark, was about $10,000 that they were campaigning for. And then over on the left here, you can see from 0 to 100%. So the most common thing was for treatment cost, but then the next most common category was losing wages, then living costs, and then underinsurance. So insurance not covering things enough. And I thought this was a illustrative quote. So the person posting the GoFundMe to support a patient with cervical cancer. So she's had to endure daily radiation and weekly chemo, but unfortunately her job did not offer short-term disability benefits. So she's had no income since being hospitalized and has no way of paying bills or paying for prescriptions. So we can really see here, unfortunately, the strain that this can put on patients. So what can healthcare teams do? I just list here a few things. So one is healthcare teams need to be aware this is a problem and start screening patients. There are different screeners that we can use for financial toxicity to sort of normalize it. We don't want it to be stigmatized, but we want it to be part of routine, comprehensive, whole person care. So if we identify patients at risk, then maybe we can link them to resources. There is a push to try to have a little bit more cost transparency. It's a little bit complicated because insurance companies can be hard to have transparency in the out-of-pocket costs, but that's one other thing that health systems are trying to do potentially. We can help educate patients and their caregivers to give them some of the skills or knowledge that are needed to navigate the complex insurance, plans that are out there, and help them to feel confident finding resources, including through great organizations like support and resources like Cancer Support Community LA. And then again, just be available to help with patients. So we kind of want to not be as reactive, but help team up with the patient early on to help either prevent these problems from getting too big and kind of help address them early on. So what can patients and caregivers do? So, talk to someone on the care team, there can, we worry, would patients be embarrassed or not want to bring it up because they think that they're not going to get the same care if they talk about the fact that they're having trouble paying for a medication or their treatment. But ultimately, care teams really want to help link patients and be aware of these issues and link them to resources, know what questions to ask, learn more about their insurance coverage. Really, it's important to keep your receipts, bills, and keep track of your costs to help with budgeting, joining community cancer awareness, a support group to get support and advice from others who may have gone through this road earlier, and then, being a patient advocate. So the next part of the talk, I just wanted to share a little bit about in the research world. There's been a lot of research in the last 10 days describing that this is a problem, but we're really trying to move towards, okay, how can we develop solutions or interventions that can help patients deal with this issue? And so when we think of it in this way, there's all these different levels that we can develop these programs. So you can see there's like the individual level, interpersonal, so between the healthcare team or maybe even the employer and the patient. Organizational would be like the health system developing programs. Community organizations are so crucial. And then really state and national policies, and then also insurance companies. So all of these stakeholders, essentially all these groups, parties, really need to be involved. And there's not going to just be one solution, unfortunately, that's going to fix this, but we need to do like solutions at lots of different levels. So I'll just provide some examples and then I'll tell you a little bit about some studies that are ongoing. And then at the end, I'll also have a list, which I'll share after, of some good websites that might have resources about some of these topics. But okay, so at the individual level, we could help, again, educate patients, their caregivers, their loved ones about insurance literacy and then financial management skills, and give tools, for instance, to track out-of-pocket costs. Can be helpful for tax purposes or budgeting or making sure, that if there's discrepancy that those are addressed. With between the provider and employer. So if we are proactively communicating about the cost of care and helping to identify patients' financial concerns, then we're going to be able to deal with them better. And then also the thought is if we can better manage patients' symptoms, so avoid unnecessary hospital stays, or help them anticipate things so that they take less time off of work, that might be a way also to decrease financial burden. At the organizational level, this is where a lot of my work has been, but we want to develop financial navigation services. So again, normalizing, bringing this up in routine care, and then having a system in place for patients who identify that they're struggling with some issue, transportation, paying for a certain drug, having the team that can then, in a very sensitive, because this is a sensitive topic, but in a compassionate way, talk to patients and help them over time find solutions and navigate some of the complexities. Rehabilitative services, that's like to try to keep patients working if they're able to. Employers should, certainly certain types of job have more work protections than others in terms of Family Medical Leave Act or paid time off, or, ensuring that the job is held while someone's taking time off from work for a cancer diagnosis, but it varies widely. Community organizations often are where patients are accessing financial programs. Pharmaceutical companies sometimes do also have an assistance programs for specific drugs. And then finally, we know I was kind of telling you the trends that are contributing to this problem. So the more people we can insure, the better. The less that we are requiring of the patients to be paying out of pocket rather than other people, being like the health system or insurance paying, could help, at least from the patient standpoint. How can we rein in drug costs? And I spoke a little bit about worker protection. So job security, being able to keep insurance even when you're not working, those types of things. Okay, so again, I'm just going to use a few high-level examples. So first, at the individual level. So this is a survey that was done of insured individuals across the country. So they asked these people taking the survey to define these 4 terms: deductible, co-insurance, co-payment, and out-of-pocket maximum. And basically only 4% of the surveyed people could actually define all 4 of these terms correctly. And then this is a busy graph, but basically even people who thought that they knew the right definition of these terms, 20 to 30% actually got them incorrect. So just to briefly review, so we talked about premium. So that's how much you pay to have insurance monthly, and it's usually monthly. So that's the premium. Deductible is the amount that you have to pay out of pocket for services, and you have to hit your deductible before the insurance company starts kicking in and providing some coverage financially. Co-insurance is where if you have a service, you pay a certain percentage. So if you go get a CAT scan, you're going to pay 20% of the CAT scan, and your insurance is going to pay 80%, as an example. Whereas co-payment is, okay, I'm going to the doctor, instead of paying 20% for all the services, I'm just going to pay $25 each time I go and have that service done. So it's a set flat rate. And then out-of-pocket maximum is for the patient themselves, individual. What's the out-of-pocket? What's the maximum in 1 year that they may have to pay out of pocket? So those are just important terms to know. But we know that this is complicated, right? So for people who haven't maybe used their insurance a lot and then suddenly need to use their insurance a lot because they have been diagnosed or their family member with cancer, then it's sort of like you're scrambling to figure out these and many other components of insurance that are very confusing and have a lot of red tape. So this is some work that I'm continuing to do. So this is an earlier version, but basically we started to develop using a lot of resources that are online from reliable organizations, which again, I'll share at the end. We like sort of a booklet that a lay educator on the healthcare team, but doesn't have to be a medical professional, could go through some of this information with patients. So we have health insurance terms, understanding medical bills, if you're employed, questions to ask your doctor, questions to ask your employer, things like disability, Family Medical Leave Act, et cetera. And so we've done focus groups in Alabama and then now here in California. And so the booklet looks totally different based on their feedback. But so we're really developing this and really trying to get patient and caregiver feedback, as well as care team like social workers, nurses, physicians, patient navigators. So we're really trying to get a lot of people's input. And then we're going to do a little pilot study here at Cedars to learn more about what works and what doesn't, and if it has an impact, acknowledging that patients are getting a lot of information around the time they're starting treatment. But then hopefully eventually it can be rolled out to many other different places and regardless of cancer type and things like that. So that's something we're working on. Again, this is an earlier version because you can see there's a lot of, it's very busy, but so some cool other things that researchers are working on to address this. So this one's called the DISCO app. It's being run out of a center in Michigan. So these researchers, Dr. Hamill and her group, basically developed an educational video, and then patients who are using it enter their employment and insurance status. And then there's a list of potential financial concerns that they can indicate. So they go on this app. I think they have iPads in clinic, is what I was told they do. And so they do it like while they're in the waiting room. And so they receive a tailored question prompt list. And so it gets printed out actually in the clinic, and then they take it and they are encouraged to ask their doctor basically these question prompts essentially about their cost of care to help, again, normalize it and help facilitate the conversation between a patient and their provider or the care team. So they're doing this in patients with breast, lung, colorectal, and prostate cancer. So they're going to compare people who are getting usual care as it is now, people using this DISCO app before the second time they meet with their oncologist, and then a group that has, uses the DISCO app, but then they also get a reminder, email or text 2 months later, if they haven't talked to them, to talk to them. And so they're going to do surveys throughout this period of time, and also actually video record the visits to see, having this question prompt, does that encourage patients and providers to have more cost discussions or deal with financial concerns more proactively? What's the quality of this communication? Do they get more referrals for financial support? Do they have financial toxicity? And how do they adhere to their treatment? So that will be interesting to see how that plays out in the clinic. This is another app. So you can see some of these are app-based, called the Teamwork app. So talking to employers and medical staff about work app. So this one is currently being tested in breast cancer. So you can see that's why it's pink. So this is kind of a two-pronged approach. So one of them is actually helping patients deal with employers. So, okay, so you're diagnosed with cancer, you have to go through treatment. It actually has a negotiation coach. So it has like different question prompts that you could ask your employer, or like brainstorm accommodations or adjustments that you might want to ask your employer for. So that's sort of like one part of the app. And the other part is actually symptom monitoring. So like, okay, do I have anti-nausea medicines? Do I have to take steroids? How can I track my symptoms so that I mentioned, like, if we can control patients' symptoms better, maybe patients can, if they're able, work part-time, or things like that, again, to generate or maintain their income. So this is focused right now on breast cancer, but clearly could be extrapolated to other groups who are receiving chemo. So half the patients will receive the Teamwork app, and then some are just getting an information booklet with some similar information, but it's less interactive. And so they're going to look at over time, what is the individual's work status after they've completed treatment, right at treatment completion, and then 1 and 2 years later. And then some other questions about whether they got work accommodations and how their symptoms were managed and how they adhered to treatment. I kind of mentioned that that we really can only address this problem in the health system or in the clinic if we ask or screen for it. So we actually did a pilot study where we did screen all patients as part of routine care for financial hardship, and we did actually find. So if you remember, it's about 1 in 5 in in research environment. When we just screened everybody, it was about 1 in 4 screened positive for financial hardship using that same tool that I described earlier, the comprehensive score for financial toxicity. So this is when we did about 364 gynecologic cancer patients just at one center. And actually 70% of patients, we then had a follow-up question that asked, like, what type of needs do you have, like insurance or medical bills, utilities, transportation. So actually 70% of people who had financial hardship reported that they had a financial need. And then people who did not have financial hardship, there was still 20% that had a financial need. So it is a prevalent issue. This is a pretty interesting / novel study that's being tested at in Philadelphia, in Pennsylvania. It's called the Guaranteed Income and Financial Treatment or GIFT trial. So it is being funded by philanthropy. So basically patients who receive a cancer diagnosis, are on chemo or immunotherapy within the last year, are on Medicaid to maybe lower income, and then are Pennsylvania resident. They're being randomized, so that's flip of a coin. Half are going to get $1,000 per month universal income, and then half are not going to get that. And then they're going to compare, does that sort of monthly allowance essentially that they can spend on whatever help decrease financial hardship or toxicity, improve their quality of life, improve their treatment adherence, lead to less food or housing insecurity or other things. So that will be, pretty novel, but will be interesting because it may be harder to do across many different health systems. But okay, and then we know that community organizations are super important. So this was a cool one done out of Washington State. So the Fred Hutch Cancer Center, this nonprofit organization called Consumer Education and Training Services, which provides a lot of financial counseling, actually separate from healthcare, just general financial counseling or counselor training or budgeting. And then Patient Advocate Foundation, which is actually a nonprofit organization that also provides direct assistance as well as resources to manage issues. So they actually did a pilot where these three, so again, a health system and then these two nonprofits all partnered together for cancer patients. And so they basically did a financial literacy course in the beginning. The financial counselor met with them monthly. And then the case manager helped to find, sign up for insurance or disability or find assistance if they needed to pay their bills monthly. And so in this small pilot study, 30 patients, they found that 60% did at least one of these three components. And it did decrease anxiety about costs by 33%, although the financial burden itself in this short period did not change. But just sort of interesting and a good example of how, lots of different people are needed to help patients with this complicated issue. So another important policy that we just need to be aware of is the Inflation Reduction Act, which was signed in August of 2022. So the two things to know about it. So one is that patients with Medicare Part D, so that's people with Medicare who have prescription drug benefits called Part D. Basically, there used to not be an annual out-of-pocket maximum for prescription drugs, which seems crazy. So now there is an annual out-of-pocket maximum of $2,000 starting in 2025. And then before, it's a little complicated to describe, but people may be aware of it, there was this donut hole. So depending where you were in your spending for prescription drugs, you may have different costs for the exact same drug. And so it's just very hard to plan or budget for. So now that's sort of being fixed or closed. And so there should be more consistent out-of-pocket costs, from monthly fill to fill. And then the other part is that the government now will be able to negotiate for certain brand name drugs to negotiate for lower prices from drug companies. So there are a few cancer and like blood clot treatment drugs that are on the list. So not totally affecting cancer significantly, because again, I think it was like 3 drugs when I looked about blood thinner and cancer, but is sort of a novel way that they're trying to rein in the high drug costs. So main conclusions, and then I'm going to share some resources, what I'll go through. So financial toxicity affects at least 1 in 4 cancer patients, and it includes monetary and time costs. We know it can impact patients' financial status, their quality of life, and health outcomes. So really, you know, us as care providers, health systems, we really must address this. Universal screening is a first step, because if we don't identify the problem or who's at risk, then we're not going to be able to help intervene. And then there's not going to just be one solution, unfortunately, because it's extremely complicated. So many different stakeholders, whether it's the provider or the clinic or the health system or your employer or nonprofit organizations or community organizations, insurance companies need to play a role, and then clearly policymakers. And then the major national policies that I just think are important, because I do think there is some recognition that this is a huge problem for people across the country, is the No Surprises Act and the Inflation Reduction Act. Okay, so again, this will be shared after, but so these are some cool resources that you guys may or may not know of. So American Cancer Society, and again, this is focusing on like affordability of treatment. So and then the American Society of Clinical Oncology. So they have specific things related to finding and paying for treatment. If there are certain terms people don't know how to define, so the examples were like deductible or prior authorization, things like that, there's a health insurance glossary that I've read there. Some other groups are Cancer Care, Patient Advocate Foundation, Patient Access Network Foundation, and then people may or may not be aware of, there are a lot of actually ones about for either patients or caregivers dealing with like employment or work concerns. So Cancer and Careers, Live Strong, Triage Cancer / Triage Health has a plethora of resources. There's worksheets, there's like 5-minute videos, there's webinars that are recorded. And then the Job Accommodation Network is good if you're trying to negotiate with your employer for accommodations or things like that. So again, we'll provide this later, but these are just some, and obviously it's not completely comprehensive, but these are national organizations, so available to anybody across the country. All right, and then it was mentioned in my intro, so I am part of this Emotional Wellbeing and Economic Burden Research Network called Emoticon. It is focused on research, but I think, you know, research is how we find the evidence of what's the best way to deal with this problem. And so if you just want to check out what we're doing, the X name, I need to change that, is emote_econ, and then we have a website, emote-econ.org. And then I'm going to stop sharing, but then I'm happy to answer some questions. And then I'll go over here. Okay. So I'll answer some questions here. So, okay. How widely is state disability being used by cancer patients who can't work while going through treatment? Is it something that is easily accessible to people? Yeah, that's a good question. I don't actually know the stats for across the state, how often it's being used. I do think it's probably underutilized because cancer is a qualifying condition and patients or their families may or may not be aware of that. And I definitely think it's something, you know, people should consider. And often healthcare provider offices or social workers in their office or case managers are the people who could help direct individuals to the correct website. So I think that's a great suggestion. Someone asked, is DISCO available to anyone or is this just for the study? Right now, I'm pretty sure it's just for the study. I guess you could try to look up DISCO app in the App Store. I might be able to do it in a moment, but I know they're testing it. They were funded by the American Cancer Society. So the goal, I think, longer term, you know, if it shows that there's some impact, would be then to make it publicly available or things like that. Yeah, I don't see it when I look it up, but great question. What does current research say about quality of care for cancer patients in treatment who have Medi-Cal? theoretically the cost-effective option versus cancer patients who are on private health insurance? Yeah, and actually, excellent questions. I think there's always questions about how does insurance affect patients' access to treatments, who pays more or less. I don't know the answer, unfortunately, but I think it is an important question. And sometimes, it's hard to change insurance at certain times, but I think that's one thing, particularly in California, that's a big problem is, there are pretty what we call narrow networks where health insurance companies have pretty limited contracts. So they really want their patients to only see providers at certain places or in certain practices. And so it can be actually kind of hard sometimes to access cancer care because there's a lot of hoops to jump through to even figure out who it is they want to see. So yeah, it's a good question. I'm sorry, I don't have the specific answer, but, and then I know sometimes, people with Medicare, for instance, might actually, if they're able to have supplemental insurance to have, more than one insurance helping to cover. I know patients have mentioned to me, especially in my research work, like people who have cancer policy, so maybe they purchased it before they're diagnosed with cancer, so it's separate from your insurance, but then may actually pay for some of the, or reimburse you for some of the costs. So, and then there's a thank you for discussing the crucial topic, long overdue, to educate patients and families. And again, I really encourage people to look at the resources there because that's a whole, topic in itself, but there's really wonderful resources out there.
Thank you, Dr. Liang, for your very informative presentation. It looks like we're still getting a couple questions in, so if anyone has any other remaining questions, please feel free to put them in the Q&A.
Yeah, this is a really good point that one of the attendees is mentioning. So the expenses associated with participation in clinical trials when insurance does not totally cover it, nor does the sponsor. So the person running often the pharma company or the government. Yeah, and I do think not only cancer care is becoming really complicated, but especially on clinical trials, there's sometimes like even more frequent lab work or more frequent CAT scans or more frequent visits, even than with sort of traditional treatments. And so it can become a lot of both monetary and time burden when patients are, not only accessing clinical trials to potentially, with the possibility of benefiting themselves, but really still benefiting future patients in drug discovery. So I think there is growing awareness of it. But yeah, it's a complicated problem, but I appreciate you bringing that because that's really big. And then who is the first maybe department or individual a patient should discuss costs with? The doctor, hospital accounting, hospital social worker? Yeah, it's a great question. So I think it's a few things. So sometimes it may be more than one person that, a patient or their family need to ask. And so it probably differs depending where the health system is. Interesting, we did some interviews asking, it was breast cancer patients who were in remission, but, and they actually were like, well, I don't really want to talk to, and again, it's different for everyone, but it was just interesting. In general, most of them said, I don't really want to necessarily talk to my doctor about it because my doctor's busy thinking about what my care plan is and managing that. So I would prefer to talk to somebody who's trained to be sensitive about the topic, knows how to keep my information private, but maybe actually has special expertise in finding assistance or dealing with my medical bills or setting up a payment plan. I think in a lot of practices, it often is a social worker. I do think a lot of, unfortunately, some of the challenge, like even just me as a healthcare professional, is like, when I'm seeing patients at my practice, like I am not really seeing the billing and things. It's like happening in this totally different area that I'm really unaware of. It's, run by the hospital. And so really also having to connect with the billing, hospital accounting or billing to find out things about payment plans particularly, I think is really important. And the nice thing, some of those organizations, I just mentioned Curious Cancer because I do some research projects with them, but like and Patient Advocate Foundation has this too. Like if you are dealing with barriers, like at wherever you are, they actually have people who will do like confidential one-on-one calls to help be like, okay, you've done the things that you know how to do, like what could be some other steps you could take. So I think that's a good resource that you could look into also. And then another question is, can a doctor revise a treatment plan based on cost? Yeah, it's challenging. So I think one is if we know that there's financial hardship for the actual treatment. Sometimes there are actually either copay cards if it's an oral cancer drug, which actually can be pretty expensive, or there are financial assistance programs that we can look into with the drug company. So we just definitely need to know about the issue. More of the time, it can be hard, more of the time in terms of adjusting the plan, there might be like some cases where there's several treatments that are maybe similar in effectiveness, but one is like once every 4 weeks and one is like, every week. Then clearly the one that's every 4 weeks, again, if they're otherwise similar in terms of the likelihood it will work or side effect profile is safe. I think that's more of the way that we adjust it. But really still knowing, again, so that we can, try to see if there are financial assistance resources. And sometimes there are like national or regional grants that people can get like for like miscellaneous costs, depending on like disease site or something like that. Okay. So in dentistry, the dentist office will give you an estimate of the treatment plan before starting the treatment. Is it possible to do so in oncology? Yeah, great question. I think I recently took my dog to the vet and they actually did that exact thing. And they were like, this is what we're going to charge you exactly. And it was like line by line, which was interesting. I was like, this is so different than, human healthcare. But so I think some places are trying to do this. So at one of the last places I worked, which was in a different state in Alabama, we were able to try testing this, but it was hard because there's so many different insurance companies. So all we could really provide was only Medicare patients. And we could tell them how much out of pocket they would pay once a month specifically for their chemo. But you can imagine there's so much other costs. It was just very hard, even for the health system, to be able to track that down ahead of time, because a lot of it is sending the bill to the insurance and then seeing what they, send back and things. So I think that's like an ideal state, but we're kind of far from that, unfortunately. There are some laws about price transparency, especially about like imaging, how like different hospitals or offices are supposed to post like how much a CAT scan would cost here versus there. So individuals in the community or patients can price check, but I actually think there's been lower uptake, of actually posting those things. So people are trying, it's just not as easy. It's easier said than done, I think. Great question and point though. Okay, so another attendee wants to say, it's worth mentioning that chemo or treatment drug manufacturers have their own programs to sponsor some patients that may have. This could help expense the actual drug, but you would still be responsible for infusion visits and administering the drug through insurance. Speak with billing to see if this can help apply for you. Yeah, and that's a good point. Like a lot of the pharmaceutical assistance programs, because they recognize that the costs are expensive, so they often have programs, but then it's not going to cover like the cost of like getting the infusion in the office or things like that. So that would be more something you would talk to like the billing office about. So good point.
Thank you for answering all of those questions. We also have a few questions that we received during registration. And I believe we have time for a few more of those, so I can go ahead and ask those. If anyone else has any questions, please feel free to put them in the Q&A. But someone asked during registration, how can social workers and community health workers assist families impacted by financial toxicity within cancer care?
Sorry, can you say it one more time? I didn't totally follow it.
Yeah. How can social workers and community health workers assist families impacted by financial toxicity within cancer care? Okay,
I gotcha. Yeah, I mean, I think so much of it is institutional or regional. So I do think it's important really to get a lay of the land. So often it is figuring out, so at my current job and my last job, like you would think it's easy, like find the patients who are having financial hardship and then link them to resources, but there's so many different people that each have like kind of a little piece of that role. So I'll use an example, like people who are on oral cancer drugs. If we want to get a financial assistance program, like the actual oral cancer drug pharmacist is the one that needs to help us identify if there's a program and sign up for it. Versus, I think one of the attendees mentioned like signing up for disability. So often, we can only like usually often it is a social worker, or maybe a patient navigator, excuse me. can like guide someone to the website, but they may not be able to actually like fill out the form with them. So there's still a lot of things. So I think kind of getting the lay of the land, who's available in the institution, what research are there, also networking with community organizations in the local area. There are like clearly like searching on the internet, but you have to make sure that what you're looking for are reliable organizations. But those are just some ideas. One thing too, for people who are in healthcare professional roles, the Association of Community Cancer Care Centers, ACCC. So this is more not for patients and caregivers, but actually has training. So if someone works for an institution or practice that is an ACCC member, they actually have this thing called Financial Advocacy Bootcamp that actually does free like online modules to help understand medical bills and be able to talk to patients about it or find assistance. So that could be a good resource for people in the healthcare professional role.
Great, thank you. And then we also have one other question from registration. Someone said they're unemployed and depleted of their savings. I know you gave a few resources for people to help pay with their treatment, but do you know of any grants or resources that help those in remission?
Yeah, that's a great question, because there is definitely, we know, both in research and then clearly from the lived experiences of people, it's not just when you're on treatment, these things linger and actually can impact sort of like generational wealth, like kids, if you're saving money for your kids' college, but now you're using for your healthcare costs as an example. Yeah, off the top of my head, I haven't just been asked that, so I don't know specifically. I do think sometimes if you find, but since I'm not the one helping apply for it, like disease specific ones, like if you have a history of it, you may still be able to qualify, but I do hear what you're saying, at the end of the day, sometimes there are limited pools of resources. Like I know the financial counselor I used to work with said there would be these grants, but they would, have so much money that they were setting aside, but then it would be like, they would go through the money basically within a week. So if you didn't apply within a week, that grant was closed until, the next opportunity. So, it's challenging from that part ultimately.
Perfect. Thank you so much. I think that is all the questions we have received. Once again, thank you, Dr. Liang, for sharing all of this wonderful information. I know a lot of us don't know how to navigate everything, and it can be very confusing. So you helping us out today we just truly appreciate it. And then we have one final closing slide. Thank you, Kathy. So if you would like to learn more about Cancer Support Community Los Angeles, please feel free to visit our website at cancersupportla.org. And if you have any questions, please feel free to email us at info@cancersupportla.org. Dr. Liang has also graciously agreed to share a copy of her slides to anyone who emails us. So if you would like a copy, please feel free to reach out. Once again, I want to thank Dr. Liang for spending her time with us today, and we truly appreciate you sharing everything. And thank you to our participants as well for being so engaged. We hope to see you at our next webinar.